But before we start the proceedings, may I bring to your attention some housekeeping matters. There is no expected fire alarm today. Therefore, if the alarm sounds, please follow the fire and emergency procedures that are applicable to the council house, which is basically leave by the door here and go out to the front. Follow Elliot, he'll be leading us. This meeting will be broadcasted live to the internet and will be capable of subsequent repeat viewings. By entering the Warspite room and during the course of the meeting, committee members are consenting to being filmed and to the use of these recordings for webcasting. Please can I ask that you speak clearly and directly into your mic when addressing the meeting so that the online participants and the public can hear, and that it is switched off when you are not using it, and that your mobile devices are turned to silent. I'm conscious that we've had a few apologies, Elliot, for today, and then I think what I'd like to do then is just to go around and everybody introduce themselves once we've found out who's not here.
Thank you, Chair. Apologies from Councillor Nicholson and apologies from Mark Hackett from University Hospitals Plymouth. Rachel O'Connor substituting today. Thank you.
Excellent. Right, so Jemima, I'm going to pick on you first and ask you to introduce yourself to everybody.
I'm Councillor Jemima Lang. I am Deputy Leader of the Council and I have the Children's Social Care Portfolio.
Thank you. It's Gary Walbridge, Plymouth City Council Strategic Director for Adults, Health and Communities.
Good morning.
Can you put your mic on, please?
Start again. Good morning, David Haley, Strategic Director for Children's Services within the Council.
Good morning, Tony Gravitt. I am the Manager for Health Watch Plymouth, but also representing Health Watch Devon, Plymouth and Talbot.
Good morning, I'm Chris Morley. I'm the Locality Director for Plymouth in NHS Devon ICB.
And congratulations on your appointment.
Good morning, everyone. I'm Rachel O'Connor, Director for Integrated Care, Partnerships and Strategy at University Hospitals Plymouth, deputising for Mark Hackett, our CEO today, likely to be the regular member on behalf of UHP. So good morning.
Welcome.
Morning, everyone. I'm Bob Fern. I'm Executive Dean of Faculty of Health at the University of Plymouth.
Thank you.
Morning. David Jones. I'm one of the clinical advisors working alongside Chris at the ICB, but also a Plymouth GP as well. So thanks for inviting me.
Elliot.
Hi there, I'm Elliot Warren-Gould. I'm Democratic Advisor for Health and Wellbeing Board.
Hello, Ruth Harrell, Director of Public Health at Plymouth City Council.
Hello, good morning. I'm Cathy Watkin. I'm a councillor in Plymouth Rutherford and Vice Chair of this committee. Thank you.
And I'm Mary Aspinall. I'm the Cabinet Member for Health and Adult Social Care, but also Chair of this august body. Thank you, everybody, indeed. If we turn to item 2, it's saying declarations of interest. Anybody wish to make any declaration? Nope. Excellent. I don't have any urgent business because we've already said hello to everybody, haven't we? So I'm quite happy with that. There are minutes from the last meeting that was held on the 24th of July. A fair number of us were here for that. So is there anybody want to raise anything from that? No. Can I have a seconder?
Yes, I can second that.
Thank you. I will sign them and they will be put into the annals of the council for future generations to read. I'm sure they'll appreciate them. So that brings us on to item 5, which is the Peninsula Acute Sustainability Programme, commonly known as PSAP, and it's a draft case for changes. Liz, welcome. Thank you very much indeed for coming along. The floor is yours.
Thank you very much for allowing me to come, and I'm joined by Jane Harris, who is my comms lead and is supporting the PASP programme. So the world changes quite rapidly in the NHS. And when we set out to come and share with you the progress that we're making with the programme of work called the Peninsula Acute Sustainability Programme, it was without the knowledge that the Darcy review would be published today. And it is likely that we're going to see the government signal a number of programmes of work, which might mean that what I am here to talk to you about will be subject to change. And I think it's probably important that we acknowledge that, particularly around the way in which we engage with the public and our key stakeholders around this programme of work. And you may take a view that you want to change how we manage it today in that context. What I think is, having had the opportunity to review the headlines summary from the review this morning, not having had a chance to look at the whole report, and having had a bit of insight from a meeting with chief executives last week, actually what I find quite reassuring is that some of the strategic shifts that are being described in the government narrative at the moment that we'll hear a lot more about today, as we understand our Prime Minister is currently the King's Fund setting out their plan, and we expect the Secretary of State to be doing that and putting a bit more detail on that in the House of Parliament at 10:30 this morning. But the three shifts that I think are at the heart of our strategy from a Devon health and care system around moving from sickness to prevention, a shift from analogue to digital, a move from hospital to community, I think is very much at the heart of what we are trying to achieve as a system anyway. When we set out to do the Peninsula Acute Sustainability programme, it was very much with having in mind the need to move to a much more sustainable position as a health and care system. I think we share in some very key ambitions for our local population to make sure that people have happy, healthy lives, that we have equal chances for health and well-being, support people's independence, enable them to have choice, and also to ensure that people's lives are free from harm. And our strategy has very much to underpin those ambitions. But we knew as a health and care system, if we could just move on to the next slide, please. And the next one, please, Elliot. We knew that we had some particular challenges in relation to the sustainability of the acute element of our strategy. In simple terms, we had vulnerabilities in both the sustainability of some of our clinical service offers. We have particular challenges in terms of our workforce, having the right number of people to deliver for our local population, and often we will describe that in very simplistic terms. So we've got 5 acute hospitals across the peninsula, we've got enough staff for 4 of them, and that does require us to think a little bit more creatively around how services are going to be delivered in the future. We also have to acknowledge that we need to deliver value for money, and we are spending more than we receive in income when it looks at our total acute provision. So there's a number of drivers that are put in place as a consequence for the Peninsula Acute Sustainability Programme. If we could move on to the next slide, please. So recognising those challenges, recognising our broader ambition, we set ourselves a number of objectives. One was to improve how we support population health needs and targeting health inequalities, which is particularly important, that we ensure that we offer consistent and safe acute services across the peninsula, so we have a consistent model with equity of access for our local population, irrespective of where in the peninsula they live, that we start addressing in the short term the fragility of some of our acute services by working in a more collaborative way across the system. And it's really great to have Rachel here today, because we are very much working collaboratively as a system, that we ensure that we move to a sustainable workforce model that ensures not only that we have the right skills and capabilities, but we attract the best people into our system who want to stay and develop their careers in our localities, and that we make best use of the scarce resource that we have. Now, this isn't the first time, and I'm sure a few people maybe sat around the room knowing that we've done work on acute services before. In 2017, we did a piece of work called the Acute Services Review, and in 2019, we did a further piece of work which was called the Peninsula Clinical Services Strategy, so many acronyms. And it is our intent to build on that work, because through that work we did a lot of engagement with local people and stakeholders, as well as working with our clinical staff. So our objective is to move to deliver a much more sustainable model. Next slide, please. And not only have we looked at what the data is telling us, we have talked to people in our communities about what's important to them and to hear a little bit more about their experience of receiving care in our acute centres. And what they've told us is that people are having to wait too long. And again, just from the headlines of the Darcy review that I've read this morning, that's acknowledged both in terms of acute services, but also people waiting for elective care. People are also talk to us about their experience of workforce challenges and are concerned for our staff, and that comes across quite strongly. And we also know that there is that people are very frustrated with the processes that we have in place and the number of times that how much time it takes to get to the right place in our system. And they also get frustrated that we're not as joined up across health and social care as they would like us to be. And our staff have also told us, next slide please, our staff have also told us that they are concerned about the services that we provide. They note the inequality of access to certain services. They find that the organisational boundaries can create barriers to people accessing care, and that's exacerbated by the lack of an electronic patient record that makes sure that information is shared as people access different parts of a pathway. They also tell us that they are fatigued, and for those staff that have worked through the pandemic, that's particularly notable. They also are concerned that despite the fact that we have increased our workforce significantly, and in fact the Darcy review points to a 17% increase in our workforce since 2019 compared with 2024, actually our productivity is significantly reduced. So they're really seeking to try and understand that. So that sets a little bit of context. Next slide, please. So we started the work on the Peninsula Acute Sustainability Programme about 18 months ago, and it's a clinically led programme of work that has been led predominantly by our chief medical officers across each of our provider organisations and also our integrated care boards. And what they've done is to advise us how they think we can best design our acute service model for the future. Next slide, please. And the hypothesis around this model is if you get the upfront element, so people's assessment and diagnostic functions really well developed at the front end of our hospitals, then that creates much greater flexibility on how we use our non-core services elsewhere within the system, enabling us to optimise our total capacity and capability. And so what we've done is to do that is to start designing the acute model from the front door in, focusing on medical assessment functions, our surgical assessment functions, and our paediatric assessment functions. And because of the interlinks between paediatrics, we've also sought to understand the interrelationship of maternity services more laterally. Next slide, please. So how have we done it? Well, it's a clinically led process that's involved people in our communities. And we've brought people together in a number of workshops to first help understand the problem that we're trying to solve using the data, using the feedback that we've got. And then we've engaged a number of people in helping us come forward with a set of scenarios which may be what will help us solve the problems that I have described. They are deliberately scenarios, they're not plans, they're not options, they're just a range of ideas that our clinical teams, informed by the feedback of patients and people who use our services, that might start helping us move it forward, tested against the data that we've got around the demand for services, the amount of activity we do, and also what our workforce data tells us. We've also worked with Healthwatch, who've been a really important partner in really testing some of those early assumptions. And we've used that and then shared that with our boards. Next phase, please. Next slide, please. So what have we learnt? Well, what we've learnt is that we've got a shared understanding of the challenges, and I think they reflect very much what I've described earlier on. And we've now moved on to clarify a set of key messages that have gone to our clinical staff, and we've also set out what we think the next phase of the work needs to be, which is phase 2. And if you could go on to that slide, please. Is having got those ideas, we now need to move into really developing our case for change. And our rationale for coming to meet with you here today is to get your feedback now and in the future as we move forward, subject to the processes that may be announced by government today, to get your thoughts and views around, so what is the case for change? So we build our future service model very much based on a shared view on what the problems are and what people would like to see as being different going forward. And I think what is, again, reassuring from reading the Darcy review this morning is a real commitment to hear the views of people who use our services, to understand from them what's important to them, what really matters and what good looks like. And they also talk very much around ensuring that we talk to our experts, the people who are delivering services, who are the advocates for people in our communities, but also understand what some of the options are. So our approach to developing that case for change, I think, is consistent with what we think is going to be a nationally led programme to really understand what needs to change going forward. So what is a case for change? If we get what is a case for change? If we can move on to the next slide. Well, broadly, it's a technical document that we are required to produce, but it has to be much more than that. It really has to be the baseline from which we move forward to do the design work. And we are very keen to make sure that we establish a case for change over the next few months that really gets us to a point where we've got a common view on the problem that we are trying to achieve. And we know that it needs to respond to the challenges that we've got, and those challenges are really clear. It's about managing the increasing demand at the front door of our hospitals, and it needs to tackle poor performance. It needs to address inequalities and poor experience. It needs to take account of our workforce model, and it needs to address the value for money and to deliver within the financial envelope that we have available to us. So that is the case for change that we are seeking to develop. And as a consequence of that, we will then move forward, having established that case for change. Next slide, please, to set our vision for acute services going forward. And then on to the next slide, please. And that will be something that we recognise, feel part of, and want to contribute to. But we're not starting from a blank sheet of paper. There is a lot of work going on already, and I'm sure as a Health and Wellbeing Board here, you'll be very aware of some of the fantastic innovation that's happening within University Hospital Plymouth with us as partners across the broader system. The One Devon elective pilot has been one of the big successes as we came out of COVID, using the Nightingale Hospital, where we work closely together to make sure that we optimise that capacity. It's had such a big impact on addressing some of our longest waits and things like orthopaedics, ophthalmology. We're also developing strong networks working together, and we've got some great examples of how we work together to strengthen some of our services in interventional radiology, cardiology, trauma and neonatology. And we also expect to expand that even further around oncology, ear, nose and throat, and acute medicine going forward. But we've also got some fantastic examples of how we're using technology. And as a system, we are moving forward again with something which is very writ large in the Darcy review and what we think are going to be the key priorities of the government around investing in technology that enables us to be much more rapid in the work we do, improve efficiency in the use of our resources, but also importantly, ensure that our people who use our services have much more control over how they receive services going forward. So last slide for me, if we could just move on about how we plan to involve people in developing our case for change. And at this point, I think we have to note that this might need to change, because at the moment this was developed before we knew the outcome of the Darcy review, and we do have an indication from the national team that the government is likely to commission an extensive engagement programme with the public, our staff and key stakeholders. And so how we approach developing the case of change going forward will absolutely have to take account of that. And we would want to make sure that we optimise our opportunity to hear the bigger picture feedback, it's going to be important as part of what I anticipate to be a national engagement exercise with hearing views about local services as well. But we will use a number of different methodologies to make sure that we reach all of the people in our communities that have a voice and want to influence how services are delivered in the future. So at that point, I will conclude my presentation and would be interested to get some views and particularly thoughts about, in the context of the Darcy Review and the national plans for engagement, what you would like us to take away so that we plan with your thoughts in mind. Thank you.
Liz, thank you very much. And it did seem rather sort of, I'm saying awkward that the Darcy report was coming out today. So I think everybody would know once that was happening that it was going to make an influence on this. And certainly from my perspective, I'm really pleased if we're going to be looking at engagement. What I will say is that I am very, very conscious that all in the Southwest we have people that are digitally excluded, and that one plea I would have is that we don't rely on digital for everything. And I'm going to be really cheeky here and say the council will obviously help with any venues that we're going to need, because there's so many that we can utilise that I'm sure we can manage that. And I'm looking at my two strategic directors there. I don't think there'll be, or three in fact, that, you know, I don't think there'll be any concern that we will be very, very open to hosting things. And I suppose the other little niggle that I have is about the Nightingale Hospital. Brilliant. I went up and saw it with the chair of the Health and Wellbeing Scrutiny panel, and brilliant, absolutely brilliant. And I think what my plea would be is that let's get some more of our consultants here utilising the building as well, because at the moment I know there's some, but not a huge number. Although the thought of going up there and having a hip replacement and then coming home the same day, I don't know if I'd quite fancy that on the train or on the car, but you know, I think that there's such an opportunity. It's a brilliant building, and you know, it's as I say, let's make sure we can get use of it.
I'll respond to that. Actually, might ask Rachel to come in if that's okay, just to talk about that. I think the principle that has been endorsed through the Nightingale has been highly successful, in so much it's enabled us to deliver really efficient clinical pathways. But in any complex health system, you need to have a diverse range of options that reflect the diverse needs of your local population. But what we have, you know, what has been interesting from our perspective is that the Nightingale, for the people whose needs can be well met, have given really positive feedback because they've had rapid access, treatment the same day, follow-up within their own local community. And for those who've been waiting for a long time, it's been a big change. And I think it does demonstrate what the advantages is of working across the wider system and utilising capacity and capability across all of our trusts. I think it also demonstrates the benefits of having some of our services away from the acute hospital that have got the pressures of managing urgent and emergency care. So I think it's been an important test of change, but it's not the only solution. But Rachel, I'm going to hand over to you.
Thank you, Chair. I mean, without a shadow of a doubt, you know, Nightingale, in terms of our waiting times, has been hugely impactful. And I think what I would also emphasise is what we've got now is a blend of different types of operating systems, whether it's the move that we've made with the Royal Eye Infirmary, whether it's Nightingale, whether it's some of the urology unit that you've also seen at UHP. That blend actually really helps that for those patients, particularly where they need the connected services that can only be provided on a Derriford site, that we've got that flexibility so that we can maintain that range for individuals. But I think what Liz in the programme is describing is actually with our public and the conversation, we can look more broadly now in terms of what does the shape of our ambition for waiting times in light of Darcy and others mean, and how can we best fulfil that with Nightingale. Some of our patients are travelling out to London and other facilities. You know, we want as far as possible that to be back in the peninsula and back in our local economy, and this programme will really help us assess that with examples of what's worked today and how we can build on that further. Just on orthopaedics, I've actually got the great pleasure to open some of our big breeze spaces, our orthopaedic theatres that we opened, and we're formally opening some of those orthopaedic spaces next week. So lots of moving parts that we can reflect on where we are now and where we go in the future.
Thank you. Jemima, and then Cathy.
Thank you. Talking about raising awareness and engaging people, I just would put in a plea around young people and how, and particular groups of young people, our care leavers, our care experienced young people, who certainly will be using these services, and how you will engage with them and speak to them. I just want to kind of mark that as a thing that I would like some attention given to. Thank you.
Thank you, Cathy. And then I've got Matt online.
Thank you. That's an excellent report, thank you. But I just have a concern that some people are going to be excluded if they can't travel to the centre, particularly when you're looking at ophthalmology and orthopaedics. People are not going to be able to get home on their own. They're going to need some form of transport, and some people may not be able to afford it.
So thank you for those comments, and absolutely understand that view, and it's a view that's been reflected in the other feedback, and it absolutely will be incorporated into our case for change. One of the abiding principles around this is ensuring equity of access and outcome for our total population. And we know that the way in which people access services at the moment is not equitable. And we know that we're not achieving equity of outcome. And again, that is absolutely enshrined in what we've heard from Darcy. So in developing our thinking about services, we need to be able to answer to the public that can be achieved for all of our people. That might mean that we have to be very creative around our different strategies, and transport, I think, is one of the things that we are going to have to tackle, which is not ambulance-based transport. It's not just about public transport. It will need a very bespoke model if we are going to change the way in which services are going to be delivered in the future. We're a long way from defining that. We're very much at a point of, let's be clear about what the problem is that we're trying to solve. Let's hear from people about what they want to see. And I think the Darcy report, and I think the up-and-coming engagement that we're likely to see, will give real strength and depth, I think, to that feedback, in order for us to feel confident we can design something that is fit for purpose for our local population and achieve the objectives that we've set.
Matt, do you want to go in?
Thank you. Thanks, Chair. I was just going to give a bit of a kind of call out for a long-term approach to engagement and health inequalities. So I was in London yesterday speaking at the King's Fund annual conference, which I have clearly missed Keir by one day, which was a bit of a shame. But in that, they've done a review around what does it take to respond to health inequalities, and albeit kind of focused on a national government level, you know, obviously preempting the Darcy review being announced and the fact that the new government has just come in. I think what would be really lovely to see is a long-term commitment to a conversation within community. I've actually sent quite a good chunk of you an email this morning with my thoughts on what we need to do. But what's clear, there was a quote from a chief finance officer over in Cambridgeshire saying that actually if we don't tackle health inequalities, we're going to need an NHS 3 times bigger, you know, in 5-10 years time. So you know, not to mention the kind of injustice of health inequalities. So unless we really get under the skin of health inequalities, we're going to be here in another 5 years having an even worse conversation about the access to services and so on. So it's just a plea that we kind of really put our heads together to think about what's that long-term approach.
Thank you for that. That'll be really useful. We'll circulate, make sure that everybody has a look at what you've put forward there, Matt. So thank you. An interesting time to be up at the King's Fund, I should think, yesterday. David.
Could I offer two things in support of what's been said already? Firstly, in relation to consultation with children and young people, we do have established groups that we can help to consult with. And I think there's also something which I've been trying to think about how we, well, I have been thinking about, I haven't got how we join up some of the consultation work that we undertake with children and young people in the local authority and across with our health partners, because I think there's something we could explore how we could do that more strongly together. So perhaps that could come out of this, but certainly support that point and would be helpful there. The second is that we have a number of places within communities that we've already got consultation work going on across all of our council. So again, if it's helpful, picking up on Matt's point, to tap into some of those. So you know, we're using structures that we've got and we're not thinking that we need to create something else, then again, I'm happy to help in terms of seeing how we can navigate those spaces. And I did say two, but just thirdly, one of the areas that I'm currently working on for delivery by this time next year is how we work in children's services in an integrated, multidisciplinary approach within communities. Now, I know that's beyond the scope really of this report, but I thought I would just mention it because if there are again opportunities that we could explore with regards to that, then I'd be very interested to think about. We're obviously working with Live Well on that in terms of some of our community focused services, and we've already got some good examples of that happening within our family hubs and family centres. But if there's more we could do as we're developing the blueprint and the model for this work within communities and localities, again, just happy to have that conversation. And I know you've been part of some of those discussions already, haven't you? Thank you.
And just to say, Michelle sent her apologies. She'll be joining us later. She clashed a meeting. So again, that'll echo what from Live Well's point of view. Rachel, you want to come in?
I was just going to just remake the point, because I think I just want to also recognise with our engagement just the important part of engagement with the local authority as a partner in itself. And I just want to be over explicit about that, because you know we are all here to support our population's health and care needs, and any of the work that we do, we will need to understand the wider impact and how we work together on any further opportunities. For some of these, actually, there'll be greater benefits for other partners as well as things we might need to mitigate. And I just want to oversay that, because that is absolutely the heart of what we're doing. And connected to that, the point David makes, that's why through the local care partnership with Chris, we are really looking at what is our community approach from the blueprint work we've done on our estates mapping and the needs of localities within Plymouth, because it's absolutely crucial that our community model, and for the emphasis that we've had here through a number of meetings around the left shifts that we want to make to really stabilise and expand our community offer, whether that be through some of the digital reach, whether that be some of our joint working in the kind of fuller type work, absolutely needs to go hand in hand with this. That's why we're doing that piece of work alongside with community. So again, I just wanted to be over explicit about that, so we keep these things connected. Thank you, Chair.
And I think one of the other things that we have to think about is how can we get our social housing colleagues on board with this, because obviously they're going to be a big part of the team. Bob, I'm going to put you on the spot here, because obviously the university is all part of the training schemes and all of that, and I'm just wondering what your thoughts are really about how we're going to be proceeding once we all know what's in the DARSI report, obviously.
Yeah, thanks for that. So I think it's complex. So we have the NHS long-term workforce plan, of course, and that will play into how this all evolves in terms of supply of trained professionals to deliver these changes. And from a university perspective, we're in a little bit of a difficult place with that currently, because the workforce plan outlines what the training needs are for the NHS going forward, but doesn't really provide us with a programme of delivery. So we don't really know what the underpinning mechanism is going to be to deliver those increases in nurses and doctors that we need to make the necessary changes in the NHS. But you know, we're engaging with government to elevate the number of doctors we're training at the minute, and dentists, As those places become available, obviously they're centrally allocated, so we are very reliant on central government to increase those numbers. And working really hard in nursing, midwifery, ophthalmology, for example. We're developing a Centre for Eye Care Excellence to expand our ophthalmology training. So I think we are actively engaged in the loop, but a little bit dependent upon other players in this complex ecosystem. It's hard for us to drive forward until we have that mechanism in place. I don't know if that answers your question, but it gives some context, I think.
That's great. And I can't let you sit there, David, and not say anything. So from primary care's perspective?
I think what's really critical with this moving forward, so in the space of system working, which is what we're describing here, I mean, the acute sustainability programme has to be anchored into, the Darcy report today talks about the community development and the need to develop that, and how we do that in practical and real terms, whether that's anchored around workforce, whether that's anchored around some specific specialty areas. And of course, the community programme is incredibly broad and diverse, traversing voluntary sector, local authority services, primary care, community care, many others. So I think what's really key, so it's really great to hear the presentation, makes a lot of sense, and it's great to hear it presented in this forum. What's going to be really key for this to have practical weight moving forward is how this is developed in conjunction with the community strategic development programme. And because without that, neither will work as effectively as it could. So I know there's not really a practical action that falls off the back of that, other than to say, I think regular communication when we're developing the community programmes moving forward, how these pieces of work are being developed hand in glove, really. So I suppose that would be the thing that I would suggest, and pieces of work that I've seen be most impactful at a practical and strategic level have been those when that has worked really effectively. So the real onus really is on that communication and triangulation of all of this, really. So thank you.
Well, I'm going to pick on Gary next, and then Tony, I'll bring you in at the end, because obviously Health Watch is going to be involved so much in this, but Gary.
Thanks, Mary, and thanks, Liz, as well for the information. I mean, it's a really big programme, isn't it? And it's really quite complicated, and then Darcy comes along. But actually talks about some things we were already wanting to do and talking about. We're not surprised, are we, of sickness to prevention. From an adult social care point of view, we would be in exactly that same mode, with demands are high and prevention being so important. And it's so nice. You would have talked about hospitals to communities, and we'll really advocate that both for Plymouth, but communities everywhere actually that you need to support. So I think that's really helpful. And we've heard quite a lot about from an engagement point of view, trying to really make sure we reach all of those parts of our communities. And I think local authorities can really help in that. And I think that offer's been there. But it's also really quite important, isn't it, to make sure we do that. And that becomes, for me, the same. And this is just to emphasise these points around whatever the model is going forward, about that inclusivity of access for everyone. And maybe for me, it brings back the importance of place. And I think inside of all of this, as you make progress and you start to get towards solutions, there will be physical places where we need to do real things. And my question around that would be, Plymouth, like other areas, have already identified physical places and real things we can do. Now, they might get shaped differently by this work and by Darcy, but the question would be, how do we coordinate that into a single set of programmes that really deliver in places? Because I think, for me, that's been difficult for us, but also it feels really important as a part of the work that you're doing.
Tony, and then I'm going to be cheeky and then say ultimate word to Ruth. So, all right.
Thanks, Chair. And I think I would echo both the thoughts of Gary and David around this sort of coordination of all engagement that's going on, because there's a lot of cross-pollination between when you speak to a particular group about one issue, it will throw up other comments with that, and how do those comments then get back to the place they need to get back? So And I think part of that is for services, providers, commissioners to kind of have a dashboard to understand what engagement is going on around the patch, whether that's local to Plymouth or wider across Devon. So that, you know, if you are planning a bit of engagement, you may see something already going on that you can tap into. And I guess that's the plea. I think from a Health Watch point of view, we're already in conversations with Liz and the team about the next phase of engagement. Obviously, we'll see how that develops following today's review publication. But I guess from us, it's how we also feed in what we're hearing into those areas as well.
And that's why the work that Health Watch does is so important. Chris, I've lifted you out of my little list. Come on, I've got to let you choose. Yeah.
Thanks, Chair. Yeah, I mean, I'd echo what's already been said in terms of really positive to hear that the work that's taking place in the alignment to our local ambitions and some of the activity that's already taken place through the local care partnership. Similarly, I would agree in terms of the engagement opportunity. So we've already started to have some conversations through the Plymouth LCP about reshaping, reviewing our commissioning strategies and what they look like, and absolutely the alignment to this and how we simplify some of that engagement to make sure we aren't all talking several times around similar things, to bring some of that together. I think hearing the work that's taking place today is helpful in that place as well.
Thank you. Ruth.
Thanks very much. So obviously many of my colleagues, which is great to hear, have all raised those issues around being inclusive and understanding the barriers that some people face, and yourselves being the first to acknowledge that. So obviously that's really welcome, because sometimes when we talk about productivity around care, that can be quite a tricky statement, because there are many ways that you can improve productivity, and some of the examples you've given are all kind of behind the scenes as far as the patient's concerned. So that all makes, you know, perfect sense. But obviously we've always got that tricky balance around care about, you know, what's important to people locally and how we need to deliver certain elements locally. But I feel confident that that is being taken into account in the way that you're approaching that, which is fantastic. And I think, you know, the Darcy report is really helpful in highlighting some of the issues with the NHS and the way we need to improve. Whilst obviously my focus is around prevention, part of that prevention is also preventing people from becoming chronically ill from a condition that actually is treatable, and that you do see that happening when waiting lists are so long, you know, something where perhaps you might be able to get treatment and get back into work. If you're waiting months and months and months for that treatment, then that can become something that makes you what's the phrase, economically unproductive, I think, is or inactive is the phrase, isn't it? And so actually, and obviously we're seeing high rates of that at the moment. So I think in terms of that sort of prevention agenda, there's an all-round win if we can actually deliver on some of the sentiments that are being talked about around the NHS being more productive, but being so joined up with that community care, that early prevention, and that sort of sense of how we need to work with people locally. So I think, yeah, we'll have to hear. I think it's going to be a month or two before the longer term actual plans come out, and what Darcy is talking about becomes a bit more in terms of the actions that we're likely to take. But I hope we can all take a lot of confidence from the way the conversation's going in this room to show how we, you know, our intention is all to work together for the benefit of the population. Thank you.
Thanks. And I'm very conscious that it's coming up to conference season for the various political parties. So certainly if there's any nuggets that you want taken, I know Tudor is very adamant he is going to rugby tackle West Streeting up there at the conference. So if you have any little nuggets that we can feed to Tudor, I think Jemima's going as well, and I think there's a couple of others that I know are going for the cabinet. So I think if any of us have anything that you want to impart, it's always good to have that, to sort of have that list. All right. So if you want to let Elliot know of anything, although I suppose it's political, no, it should be all right, because it's asking, isn't it, rather than anything else. But we'd be very, very happy. And I don't know, Kathy, if there's any of your team going. I'm going. Right, well, there we are. We've got another voice then to the Conservative. conference as well. So let's make use of it. You know, that's what it's all about. Can I thank everybody for their contributions to this, and it's a really important. So Liz, I know full well you'll be coming back.
Yes.
Whether, I mean, I think our next meeting's not till January-ish. So hopefully by then we'll have a few more sort of things that have been said, and we know where actions go. And horribly, another reiteration of this report. And so our recommendations today are that the Health and Wellbeing Board endorse the approach that we are taking in engaging with local people, and the Health and Wellbeing Board support raising awareness locally and encourage local people to take part in engagement. And as I say, I think the third one needs to be that the next part of this report comes back to us as soon as it's able to. Are you happy for those three recommendations? And does anybody else want to add one? No? We're all happy. Excellent. Thank you.
Thank you, Chair, for your time today. The feedback is really welcome, and subject to whatever change comes out, we will, through the national programme, we will come back and update you. Thank you for your time.
Thank you. Right, Tony, you have been busy with Health Watch, haven't you? Nobody's been sitting down doing nothing by the sounds of it. So I gather we've got two reports. So if you want to take your annual report first, and then we can move into the other one, which I think is very interesting and prudent at the moment. So the floor is yours.
Thank you, Chair. Let's see if we can just get this to work, because it doesn't seem to want to go into presentation mode. There we go. So firstly, we'll take you through some of the key points and highlights from what we were up to in the last financial year, and go through our annual report. So what we are, or what I am going to talk about this morning, is really different ways we've connected with people, some of the impacts of that connection, and some of the report work that we've done. And I guess there's a message there from our sort of overall chair for Health Watch Devon, Plymouth and Torbay in the report, thanking everybody who supported us in our goal to monitor and improve health and care services. So how does Health Watch work? This is really just a quick reminder. We are currently in year 4 of a contract that was jointly commissioned by the 3 local authorities in Devon, and it brought together 3 partners that would host the 3 local Health Watch services. So although we still have a local branding for Plymouth, Devon and Torbay, it allows us to work quite jointly across the whole of the Devon area. And that can be sometimes around engagement, but more importantly, I think it allows us to triangulate information that comes into us from patient experience or from contact from the public. For example, something might be raised in East Devon, and we can triangulate that, see if it's happening across the whole patch or it's just specific to that location. Funding for Health Watch comes from central government, devolved down to the local authorities, and that is used to commission us. So, quite simply, our mission is to make sure people's experience help make health and care better. That is our prime statutory function, to talk to people and to make recommendations to providers and commissioners. And that could be around fundamental service change, but it could equally be around something very simple, that if the process was just changed a little bit, it makes the whole patient experience, whether that's around access or communication, better for patients. Grand vision, a world where we can get all the health and care we need. But why not? You know, the NHS was set up as free at the point of service. There's a lot of challenges at the moment that we know about, and I think the Prime Minister's statement today about a change of direction is probably the right one, but it's how we go about engaging the public around those changes and making sure they're kept A, in the picture, but B, brought on board and support what's required. And from our values point of view, I guess because we're independent, we listen independently, so we don't come with any agenda or anything. We listen to what people say to us, and we basically pull that together in the reports that we do or the conversations that we have. So, how do we achieve this? Well, I guess if we didn't have our volunteer base, we wouldn't do half the work that we actually do. Our volunteers are absolutely key for supporting us, whether that's around engagement topic, just going out doing brand awareness, doing some research for us, or representing us in some formal shape in local meetings or more strategically. We employ 15 staff, but of those, I think only 2 are full-time. So everybody else is part-time working around that. And they are generally split relatively evenly across the 3 local health watch areas. We do work within a sort of team concept, so our communications are not local to Plymouth, but they cover the whole patch. We have dedicated walk-in centres in the 3 major areas. So in Torbay, it's at Paignton Library. At Plymouth, we're now based at William Sutton Memorial Hall in St Budo. And across wider Devon, we've got HCA offices that we basically use as a health watch champion vocal point. We also have tried to and have established what we call our Health Watch Assist network, and that's going out to local support groups, voluntary groups, etc., and try and have a 2-way relationship with them. In other words, we can communicate to a specific group about changes to the activity they're involved in, but more importantly for us is for them to actually raise concerns with us or to support us with engagement. So we have done some work that has led to the Deaf Association supporting some work around BSL translation services. I think, you know, we try to make it diverse, so we're not just looking at one particular thing, but it to encompass everything, and that is something I think that's fundamental to engagement going on in the future of how we can pull those groups in to get involved. So how many people did we reach in the last financial year? Nearly 3,400 people shared experience of their services, which helped raise awareness about issues. And they can do that by various methods. We have a call centre, but equally we are digitally enabled through our websites. We have social media accounts, so there's various methods that people can come and share that. And we also have a function of providing advice and signposting. So 620 came to us on that way, particularly, I would say, about accessing dental services, wanting to know what was available. But there was other issues as well, and we do refer people in to NHS advocacy where we believe that needs to be done. As I mentioned, we've got a contact centre that's run by our CA colleagues in Totnes. We also have our free websites and use social media. I guess the other one, we have a fortnightly e-bulletin that we send out asking for feedback about certain things, but also sharing information from NHS and local authority colleagues around services and particularly service change. Comments we get, we're not just wanting to know what's not working, we're wanting to know what's working well as well, so we can come up with a balanced view on services. And there's a couple of examples there around somebody who had a very good experience and somebody who had a really poor one. And I guess what we're seeing in some of the feedback at the moment from people that contact us, the issues they're raising are more complex. It's involving multiple services. It's something that may be affecting them in one way, but it moves on to others. In terms of reporting, then in the last year, we've done 10 reports about improvements people would like to see. Some of those have been local, and some have been across Devon. So a couple of the across Devon ones have been some work in the emergency departments, trying to work out the reason why people were turning up at EDs. We also did some work around patient experience that we've received around pharmacy services, which has an exponential increase as pharmacies started to close, and that was the national pharmacies moving out. There was also some concerns raised about the outpatient pharmacy at Derriford. I'll come on to more about that in a minute. But we produce insight reports, we do a quarterly impact report, and above all our evidence that we gain goes up to the national body Health Watch England and is involved in their national reporting. So the emergency department work that we did across Devon, I think at the time that this occurred, there was a lot of pressure on the EDs across our 4 main hospitals, and it was trying to understand what was the information that people or patients were taking on to make that decision to attend the ED. And I don't think there was just one relevant theme that came out of it. There were several things. People had tried to contact their GP and either couldn't get an appointment or had been advised to go to ED. Same with 111. They've tried other services and hadn't actually achieved what they any sort of information for them about their condition. So they turned up at ED, and others had used the information that was available around waiting times. There was one chap in Plymouth who suspected he'd broken his wrist, decided that, yeah, I'm going to need an X-ray, but the waiting time at ED was shorter than it was at the Cumberland Centre, so made that decision. So people will listen to what advice is being given, and they will use that advice. So we shouldn't be surprised when those sort of things happen. I guess what it has done, though, has raised that with the urgent and emergency care boards. And I think with the other work that's gone on, I think EDs are still busy, but less busier than they were at the time that this engagement and reporting went on. We've talked about this just now, the Peninsular Acute Sustainability Programme. So we ran some focus groups last year across Plymouth, Devon, Torbay and Cornwall, looking at specific activity from the acute side, and pulled that together, which helped shape phase 1, if you like, of that. And obviously we remain involved with that project moving forward. I think this was probably one of our key reports from last year around the effects of pharmacy closures, what that was meaning to people. particularly in the rural areas where if you've lost a pharmacy in one of the towns there, actually that's an awful impact on people who may need to travel. By pulling all that together and raising it with NHS Devon, I think it's helped develop the pharmacy strategy, which the Health and Wellbeing Board were involved in earlier in the year. And I think equally the work that was highlighted by UHP around the change to pharmacy had some of the bearing from this report, from the experiences that were highlighted. Other examples of communities we've been involved with, children and young people, did some work in Torbay around particularly CAMS. Carers, we run a Devon-wide report on that about the effects of being a carer on their own health and well-being, and when that becomes a trigger and actually they need assistance themselves. And that report was published not so long ago and is being received quite strongly by the 3 local authorities around some of the things it raises. We've worked with local communities around cost of living via a social media campaign, and that was to really underline the work that Healthwatch England had done, and I think the results we gained out of that actually highlighted the national survey that was done and corresponded with those findings. Again, in Torbay in South Devon, we did some work on men's health, and that was really engaging with the male population there to find out why they weren't seeking support, advice, information, and accessing services. So that was fed back and is now being used to look at communications programs for men in that community. And again, eye care patients with the new REI in Plymouth, we did some work earlier this year around some issues around access, and that has been reported to UHP, and they've taken on board some of the findings from that. So from a recognition point of view for us, we've attended different national Healthwatch England events, shared the work we've done around urgent care, a national leadership conference of Healthwatch, and on the back of some of the work we've done, we won a commended award at the National Healthwatch Impact Award ceremony, which is a bit of kudos, I think, for us. And we've also shared lots of briefing documents about the wider working of the Healthwatch network, mainly the Healthwatch England reports that come out almost on a monthly basis now around particular subjects. And I guess the other one was the emergency department, which we presented to the South West Clinical Senate conference in Exeter earlier in the year. Priorities for Plymouth in particular for the next financial year. So every year we set our priorities based on what the public are telling us. We have agreement from our steering groups over what they should be. So for Plymouth in particular, they're around health, social care, children and young people, mental health and digital health. But I think if you wrap those kind of around into systems, that covers pretty much the primary community services. It also covers the acute services and I guess has an impact in all those areas. So we're not saying we're just going to look at access for GPs, it could be access about anything in terms of health services. And that will be based on public voice, as I said. And just finally, a quick quote from the interim chief exec, Stephen Moore for NHS Devon. I don't know if he's been confirmed in post yet, Chris.
Yes,
Yeah, so now the chief exec. And I think we've always had a good relationship with NHS Devon, who value the work we do and are able to provide insights and that into the various work strands that they are doing. So that was our year in a very quick nutshell. Any questions?
Tony, thank you. I mean, the work that's done with even that small band of stoic volunteers is just amazing. And I think it just shows you how dedicated they are. So our thanks to all of those volunteers that do that, and obviously to the team as well. But
Yeah,
you know, it is outstanding. Just a couple of things I wanted to pick up about the pharmacy. Obviously, you know that we've now started that pharmaceutical needs assessment process, and I must admit, I went on one of the workshops the other week, and for part of the time, and it's just mind-boggling. It really is, all those rules, regulations, and what you've got to put in. So hopefully, when the new one comes out, we can have at least altered it a little bit to make it a bit better. I mean, Plymouth hit the headlines with being the worst affected for the closure of 9 pharmacies, you know, in the whole southwest. In fact, it might even be. Sorry, so who's got a mic? Can somebody turn that off? Thank you. We echo that, and we will obviously keep pharmacology and whatever. And yes, the hospital's much better. I think there's less concern, shall we say, because of the thing there. And the second thing is the Cumberland. Brilliant unit. Really brilliant unit. And the only thing, Rachel, this probably comes into your domain as well, is people don't know when there's a doctor there. So there are some things they're going for which would save time at ED, but because there's no doctor, they then end up going to ED as well. So I just wonder whether there can be even something that's published to say a doctor will be there on X, Y, and Z, rather than them wasting time. Because as David no doubt knows, e-consult is great at times, but at times you can put the wrong, well, no, you can put the correct thing in and it says, bounce you out, you need to go to ED. You don't. It's just a case that you need to see somebody with a bit more skills and prescription thing than what. So I think this e-consult is great for some people, but for others, it's getting that balance now, isn't it, as to where we can get the best treatment for people without clogging the system up.
I mean, just on that point, I think what we're trying to do, obviously with our urgent treatment centre that's opening as well, is actually be really clear about the conditions and the illnesses that those areas can treat, because there's a range of professionals, doctor or nurse, actually in our skill mix that can support. So I think, I'm happy that, we're continuing to work with Health Watch and other partners, is that we describe that appropriately on conditions and what people are seeking treatment for, rather than professionally based care, if you don't mind, because I think then it becomes a clearer roadmap then of the service offer that we've got.
I think it's also thinking about the geography of Plymouth, that if somebody from, will go into urgent treatment centre first because they live in that area, and then of course they've then got to get out to Derriford as well. So I think there's just fine tuning, shall we say. I think that would be really useful. David, did you want to come in there?
Yeah, I'd support that comment from Rachel, really. I think it's defining it around the conditions that the urgent treatment centre can manage. So just as a bit of context, if you take time, I work in a practice with 40,000 patients in the East End of Plymouth, but also in Ivybridge. So I just took a typical day, and there were 286 same-day clinical contacts. So my practice probably represents 10% of the area that surrounds the hospital. So if that were a typical day and my practice were a typical practice, that's about 3,000 same-day clinical contacts. So those are people with a need that's determined, needs to speak to a trained healthcare professional, whether that be doctor, nurse practitioner or other. So I think there is potentially an unintended consequence of saying we have a doctor in at this particular time, because if 10% of those 3,000 thought, okay, well, I'm going to go to the urgent treatment centre for my general practice needs, then straight away that service would become very rapidly overwhelmed. So I think framing it around Chair, I think it's a very valid and good point that you raise. I think being really clear and explicit around what the urgent treatment centre can reasonably manage is really, really important in terms of expectation management. The danger, the unintended consequence of framing it around we have a GP on site today is people would then start to use that as a surrogate GP service, which would both overwhelm it, but also potentially for people with enduring and long-term conditions and what have you, potentially wouldn't provide a long-term solution for those issues, albeit accepting that access to general practice services is a challenge, as has been described in the Health Watch reports.
I think more I'm thinking about what 111 know, because obviously people will then go to 111, and if 111 know that this is happening, then again it would save time, should we say. And I think that to me is probably one of those things that I've learned over this last few weeks, that just that simple information can save the UTC's time, and also anybody else's time. But again, it's unfortunate that ED end up so busy because we've got so many people that need to get there for whatever reason, and and I think that's what we have to think. So thank you, Jemima.
One of my questions has been covered, but just out of interest, because I think it seems like you've spoken to a lot of people. Do other health watchers in different parts of the country share their kind of data around how many people they've spoken to and what proportion of the population, all that kind of thing? I just wondered how we compared.
I guess it's something that we don't naturally compare ourselves locally with places like Health Watch Cornwall, Health Watch Somerset, or Health Watch Dorset. We work on our own population. Health Watch England might be able to have a view on that, because we all report into Health Watch England. They get monthly downloads from Health Watch of the issues that have been raised that month and the number of people that have been spoken to. And likewise, every report we do going into a national library. I could ask the question with them and see if they have those sort of statistics at hand and come back.
I just think it's interesting, and just for context, we do it in lots of other bits of what the council looks at, don't we? Our statistical neighbours and so on. And it might be that we have, great cause to celebrate and say we're doing, look how many people we're speaking to compared to other places. I just think just as a point of information, it would be interesting. Thank you.
Anyone else? Michelle, welcome.
Thank you. I'm sorry I was late, but it was just a big diary clash. I just wanted to add, thanks to Health Watch. It was a good report to read, and certainly looking at the proposals for this year and the coming years is that it feels like the right things to do, but there's something about keeping it dynamic, and I don't know how you would feel, Councillor Aspinall, about as things come up, if there are action plans we need to put in place following work done by Health Watch that actually will bring it back to Health and Wellbeing Board.
Very happy to do that. Yes, it's wise to keep it topical, isn't it? And action as you raise it. I think, Rachel, did you want to come in there?
Thank you, and I just want to say on behalf of the Trust and the RCP how helpful the work that Health Watch has done in these reports is. I mean, there is absolute line of sight in terms of the feedback that we've had on whether it's the pharmacy work, whether it's the ED, and actually how that's influencing our plans. So the one plan work that we're doing around our emergency department, hearing those messages around the things that are working and not working have shaped some of the solutions that we're taking collectively. And I just wanted to make that point. These aren't reports that we hear and we absolutely root them then in our solutions. So just thanks on behalf of partners for the work that you've done and the improvements it's helping us make.
Gary.
Yeah, thanks. And of course, would echo that. And it was interesting, wasn't it, that we could hear Liz Davenport here earlier talking about Health Watch as part of that programme as well. So it's really vital and important. I just had two questions, Tony. And one, it's not to put you on the spot, just to see if there was any information you could share. But firstly, we spoke earlier as well, didn't we, around engagement and making sure that that in that engagement we reach all the parts of our communities. And I was just interested in your work programme, just to hear your thoughts around how Health Watch will approach that for the year. And the other thing is, I know there's some work happening locally for us in Plymouth in terms of Health Watch doing some work around care homes. I was just wondering if you did want to say anything about that for others. But
So I'll take your last point first and give an update on that to give me thinking time on the other one. So basically, we have agreed a series of care home lay visits based on a programme, and it's actually a re-establishment of a programme we started in 2019 to go around and talk to residents, but also to the management of the care home around for residents, what was it like to be there? Did they feel involved? What were activities like? Was the meal good? Did they have access to primary care services? So that was, was there a GP coming in attendance, or could they access a GP relatively easy? But also access to dental and optical services as well. So we have an agreement at the moment that we're going to re-establish that programme. We're looking at recommencing next month in October, with the team of volunteers leading on that one. But I've got some volunteers who are exceptionally enthusiastic in doing that work. So I think that's a good thing. In terms of engaging other communities, then we have, through the Health Watch Assist network, some groups that are there on what you would call probably communities of interest or minority communities that we can utilise to access into there. We have done specific forums in the past, whether that's been face-to-face or digital, with certain groups as well. So we use a variety of methods. And I think any sort of engagement work we're planning to do, it's identifying what communities we need to speak to and how we're going to do that. And that forms part of the planning process.
Thank you very much indeed. So I think we need to note this report and we need to move on to the next one, which is a fascinating read. So thanks, Tony, for bringing it.
This was a Health Watch England report that was issued in July this year, entitled The Missing Millions, Exploring Hidden and Unmet Social Care Need for Disabled People. So moving forward, so social care support is transformative for disabled people. But from the Health Watch England work, it would appear that as many as 1.5 million working age disabled people may not be getting the care they're eligible for. The work that was done as a national survey using a national marketing company. The methodology, whilst they only spoke with, I think it was just short of 1,600 people, the methodology used allowed them to extrapolate from those results into the wider populace. So Health Watch England basically set out to learn who's accessing care, who isn't, and why, and it followed a latest official proposals for social care reform laid out in 2021. which noted in its chapter on access that there is a lack of data and evidence on the extent to which care needs are not being met. And it went on to say, we believe that better quality data, including client level data, will help us to understand more about who accesses and what the impact of that is, better understand who is not accessing care, and better understand how much barriers or choices or both may be a cause of this. The Health Watch England report aimed to address that lack of data, and as I said, research was based on an online survey commissioned with a research company called Savanta, and was carried out between February and March this year, using a representative sample of 1,504 disabled adults aged 18 to 64. The key findings from this, and like I said, when they used the methodology they extrapolated out from those results, indicated that up to 1.5 million disabled adults could be eligible for social care or other support but weren't in receipt of it. When people receive social care support, their experiences are very positive, so it proves that the services out there are making an impact and making a difference on people's lives. And 78% of disabled adults agree that their care helps them to live the lives they want to live, which I guess is the best testament that you can have from somebody. Social care helps people stay healthy. It allows them to do their favourite activities. It allows them to work, and it also allows them to volunteer and give back. But it fundamentally means they can look after themselves and their homes. Only 9% of people spoke to disagree that care helps them live the lives they wanted to. So I think, again, it just reinforces that when it's there and it's being accessed, then it has a fundamental positive effect. Further findings also highlighted that access to social care remains a challenge, and 28% of the sample size never access any care, despite self-identifying as eligible. Now, it wasn't fundamentally clear from what I could see whether that was they tried to access care and couldn't, or they basically services weren't in their area for them to allow them to do that. Most people waiting for care assessments received information and support, including how long they could expect to wait for an assessment and information on what to expect. And I think it's that communication is a key part of the process as well. And it says it's worth noting that 10% of people receive no support at all while waiting. So I guess that was not even being given information. Based on the findings, Health Watch England has set out the following recommendations. Government must fund local authority public awareness of social care, improve ways of accessing that social care, and find potentially eligible individuals through proactive outreach, statutory information, advice and signposting services. Funding should be made available to local councils to boost social care capacity and support councils in addressing existing care assessments and care package backlogs. Continuing on, funding should be ring-fenced for organisations providing independent advice and guidance related to social care. And in response to broader challenges, Health Watch England recommended a fully funded and long-term reform platform for social care, addressing workforce challenges, including retention, recognition and pay. A focus on prevention of care needs and support to help people live as well and as long as possible in the place they call home. And more support for unpaid carers, including reform of carers allowance and improved access to support for themselves and more importantly those that they care for. and expand access to Care Act advocates to support everyone accessing this social care needs assessment. I think from the Darcy report today, that is evidently clear. That's one of the themes that is coming out of that, and particularly when we talk about communities and supporting people to live well in the community, there is obviously a massive element of social care in that, so there's some hand and glove. I think that the fact that that report has recognised that has actually echoed some of the findings that Healthwatch England have come out with in this report. I'm happy to take any questions.
Thank you, Tony. And I think if we think about how we as a council battle to try and get people the allowances, etc., that they are entitled to, I think this is something then that, Bruce, I think you and I perhaps have a conversation with about those people that aren't claiming what they're entitled to. I mean, to me, that is just batty. You know, if it's going to help improve your quality of your life, then, you know, we should be making sure that we contribute to making sure that people know about it. And Gary, I think I'm the bit in here that says that people are being told information and whatever, but I think that's really useful. And I suppose from my perspective, it's the fact that we're looking at the under 65s, which is when I naturally think of some of my portfolio, I just tend to think of older people again. So that this report really brought it home to me that we do have a large number of people that this affects. So I think probably something that you and I need to have a conversation with, but I do think it's something that we perhaps bring as another item back to this board at some time. So please, if you want to contribute to that.
Just to come back, and I would just add, Mary, an increasing number of under 65s coming in through our system. So those numbers are going up, and through demands that we see, actually that's going to continue to move in that direction. So just to come back on that point that you made.
Yeah, thank you. I think it's very, very interesting and necessary report. When it comes to the carers part, the recommendations, I'm just a bit disappointed. I wouldn't say disappointed, but I just wondered how the report has acknowledged young carers, because obviously we're talking about adult access to social care, but we know quite a lot of adults have children under 18 who are caring for them. And I just wondered whether the report kind of reflected on that, and then on our response to it, whether we can make sure that that is a distinct part of our response.
Tony, do you want to come back?
Yeah, I think it really looked at people over the age of 18 rather than those children that may be providing care for either parents or siblings. And I think when we publish our unpaid carers report, that was also an area that was missed. So it's kind of almost pointing to a bit of work that needs to be done to understand that for the under 18 population, and perhaps that's something I know we want to review the next phase for our unpaid carers work, and maybe that might be the topic that we look at with the carers organisations.
Can we put a recommendation forward, I think, then to you locally, just to say that? So Jemima, I think if you can think of some words that Elliot can put down that we can vote on. I'll give you a few minutes to think about that, or if you've got them on your head now, then great. Anybody else? Gary?
Thanks. I felt absolutely right for me to also just shout out, and thanks for the report. It is a really helpful report, and just wanting to agree firstly with the comment you made around the value of social care and the difference that it makes for people. And I think I would include carers as well in that. So I just wanted to kind of firstly shout that out, because I think that's really, really important for everyone who works in that in sector. I wanted to talk this morning. We talked about Darcy and we talked about moving to prevention. So I'm just really interested in this 28%, but people who are feeling they need social care and a prevention agenda, because I think for us, and it's perhaps one of those areas for us to explore more about. Prevention would often mean the services we give to people more universally and in their communities. That means they don't need to come to us because they can self-help and self-manage. That's really, really important, because I wouldn't want us to think that just because you haven't come to social care, you can't get that value and that benefit in other ways using your networks and communities. And I'd hate for us to think about that number as a failure necessarily. It's definitely one we need to watch, and it's something we need to be really interested in. But the prevention model, we saw it this morning with Liz, and when you look at social care models, they are going to talk about communities, self-help, prevention, upstream, to delay or avoid the need for people needing to come in to get the state involved in a statutory support, because also the other aspect of that is when we do, people pay and they're means tested, which you do refer to as well. And that's another alter. So I think that was just the point I really wanted to make, was this aspect of prevention and perhaps how we can start to consider that in reports around this area.
I think there's that benefit uptake, isn't it? And I think that comes back to Ruth as to think. I mean, it all comes into the cost of living and everything else, doesn't it? And I think that's one of those. I just think it still surprises me that people don't think they can apply for something that they are entitled to, but because it hasn't. That's some sort of publicity. Yes, please.
Yeah, just to update the board, we've recently acquired a data system which allows us to use a range of data that the council and our partners hold, so DWP, DHSC, and data the council have on council tax and things like that, and combine that together to form a dashboard for people who have lower incomes, with the idea of being able to spot in that data whether there are people who appear to be eligible for benefits but not claiming them. And then through understanding that, we can then target support to those people. And it may be that they feel they don't want to claim a benefit, and may feel that they are meeting their needs in other ways, which is some of that conversation around adult social care. But it also may be that they don't realise they're eligible, or that they've been put off in applying for it for various reasons. Some people feel that they don't want to access benefits without perhaps being given a bit of a nudge to realise that actually they are eligible for them. So pension credit being one of those examples, and obviously increased importance around that at the moment, with the winter fuel allowance being linked to that. And we do know that there's a considerable number of households in Plymouth who are almost definitely eligible but aren't claiming at the moment. So we're looking at a programme now of really sort of testing out what method of communication do we need to use to invite people to apply. So obviously it's their choice, but is digital a barrier to people? And so we're testing out a model with pension credit where we will be contacting people with providing them with the information that they might need to apply if they wish to apply, but also then giving them the support from Citizens Advice to either have a face-to-face meeting to go through it with somebody, with an advisor to do it for you, or do that over the phone, or various models like that. And it will be really interesting at the end of that to understand what proportion of the number chose not to apply in the end, or found it difficult to apply and required face-to-face support, etc. And from that, we've sort of picked that as a bit of a pilot, because clearly it's important going into winter this year, but also because it's a relatively small group, so we want to test out some of the models of how we do that, and then we might be able to broaden it. It doesn't combine information on people's health conditions at this stage, so we wouldn't be able to do anything around that. It is more about income. So yeah, it should be an interesting tool, and obviously, we are the more you look into benefits, the more you uncover that are smaller benefits or things that you can apply for that you're eligible for if you're on a particular benefit. There are particular tariffs for Wi-Fi and for network, what's it called, SIM, you know, on your smartphone to be able to use the network, all sorts of things that I had no idea that you could actually access, that many people are probably eligible for and not getting it. So yeah.
I think, you know, the whole idea of sort of making people aware that there are allowances that they are entitled to, I think, to me, is that important thing. So I think all the agencies working together, we would be good on that. Yeah. Jemima, have you managed to think of some words?
I have.
Well done. You're content with that? Emma nodding
My
there.
microphone on, sorry. Emma.
Yeah, couldn't hear online.
Yeah, sorry. Do you want me to say it again, Michelle? To ask Healthwatch
Yes,
Coventry
please.
and Torbay to work with Plymouth City Council to include young carers in the next phase of their unpaid carers work. And Emma has kindly said that Tony can liaise with her and her team around that.
Great.
Right, you're all happy with that? Nobody's going to dissent. Lovely. Tony, thank you for bringing that, and I appreciate it because it was a national report that you know but it shed a whole lot of light on things that given us food for thought. I think so. Thank you for that. Elliot, you're happy that we've noted all of that? Thank you. Right, let's move on to item 7, which is NHS Devon update. Chris, the floor is yours.
Thank you, Chair. So our regular updates in the pack, I'll just go through and pull out a few kind of the key headlines from the areas that are covered within it. So the first one to reference is the ICB NHS Devon's annual report on our accounts, which are due to be published actually published yesterday in terms of the paper pack, but going to a board meeting next week. Really timely for us in terms of it's the first full year of NHS Devon being in existence as an ICB, and our transformation across from a clinical commissioning group recognise the particular challenges and pressures that as a system we've faced and continue to face under the backdrop of an underlying financial deficit. But the report does show some areas of real progress that are already being made, both in terms of elective care and waiting lists, some improvement around urgent and emergency care, but still a long way to go. And many of the things that have already been discussed today and raised, both in terms of Darcy and the direction of travel that aligns to our strategic ambition, and similarly the work that Healthwatch have done around ED and other areas that's helped inform that is really, really key. The financial position, I know this was a specific ask at the last Health and Wellbeing Board that we start including this, so we'll keep reporting on this on a regular basis. But as you can see within the report, the total system deficit for this year that's been agreed as part of our financial planning programme is an £80 million deficit across the whole of Devon. But that in itself is obviously a very, very large financial deficit. But is built on the basis of a savings requirement of 213 million. So really, really significant financial pressure and improvement and performance and change that has to take place this year. There are plans that underline that and confidence in, although there are obviously so many different variables that can impact on that. Next mention is the organisational change process. So this is something NHS Devon as an organisation has been going through for some time, part of a national requirement to reduce our running costs by 30%. The process is entering its final phase now through implementation, but actually it's quite positive in some ways in terms of actually how as we've shifted from a CCG to an ICB, how we make sure that we've got the right structures in place in order to respond to the requirements that are set of an ICB. And particularly for Plymouth, I think it's important to recognise the continuation of the locality role and how we can use that to make sure that we're supporting through the local care partnership and alongside our partners in Plymouth to improve health wellbeing outcomes for individuals in the city, and also shifting more into that prevention space. General practice collective action people will be aware of, and that's something that's been taking place nationally across the country since the beginning of August. it's very complex in terms of it's a various different set of actions that practices are able to take, and therefore predicting the impact of it is incredibly complex. But we're doing an awful lot of work behind the scenes in terms of weekly incident management meetings, looking at data, working alongside partners to identify where there is any impact that's occurring and making sure that we're taking appropriate mitigating action. And we're continuing to provide regular updates to stakeholders, updating the website as well for the general public. I think that the key message as well in there is that practices are still open and that people should continue to access services in the way that they normally would. Winter is coming, and as we're very much at the moment working on our winter plan and our response to that across partners, and how we're ensuring that we've got the right capacity plans and surge response in place. There's an update in the paper around particularly on the communications piece of that. There's national winter campaigns that NHS Devon has a role in coordinating the local system response. Very much our messages again this year are in reminding people about helping to avoid infections, regular hand washing, making sure people are staying healthy, and encouraging uptake of the seasonal vaccination programme with communication plans that are in place, and we'll start with themes each week moving forwards now in terms of how we support that. And the priorities that are around that, as described in the pack, so around that vaccination, making sure people are aware of those different options that they've got to access services as well. And the last one to mention is the end-of-life review work. So people will be aware, certainly from a Plymouth perspective, through the Overview and Scrutiny Committee sessions that we've had around end-of-life, and we're due to come back again in October to provide an update around that. So there's a huge amount of local work in Plymouth that's taking place, but supporting that now is the end-of-life review programme that's been set up Pan Devon. So, and we're part of that in terms of helping to shape that, but that's very much about how do we make sure that we've got a sustainable and more consistent offer and equity in terms of access across Devon, and that people can expect a kind of standard offer in terms of end-of-life care, and how we make sure that it's sustainable in terms of working with our hospices and other partners who operate in that space. That group is going to set out a clear commissioning approach across Devon, but then our local existing groups and the local programmes of improvement work that we've got will have a really key role in how we deliver that locally to respond to the local population need, and we'll continue to provide updates around that. The only other thing to mention as well, there was an ask last time to start including more dentistry updates around this. We haven't been able to get one in for this time, but we will make sure that moving forwards that's part of the plan.
Thanks very much, Chris. Obviously, as you say, it's that changing season, isn't it? So presumably, I know at the moment GPs have been sending out invites, and obviously various pharmacies have been sending out invites for the flu vaccine. But I presume fairly soon something will be coming out about the next round of COVID jabs for those susceptible people. Ruth, did you want to comment?
Yes, they've sent out the initial information on that and who's eligible. So it's going to be, so this is for the autumn booster. So it's going to be adults over 65, residents in care homes for older adults, individuals aged 6 months to 64 years in clinical risk groups. And that obviously those clinical risk groups are quite a long list and quite broad, but they include that whole range of things like respiratory disease, heart disease, kidney problems, diabetes and immunosuppression, etc. So there's quite a long list. Obviously GP or the NHS would normally text patients or contact them to let them know that they're eligible. And frontline NHS and social care workers, as you'd expect as usual. So the information on the eligibility to come out, but the information on exactly how you will be able to access those hasn't in any detail yet.
Thank you. Because it's always useful to know whether you can have both at the same time rather than have to go back, etc., isn't it? So you may as well have two swans. So yes, Chris, thank you for that. I mean, there's something that came across I hadn't appreciated about the pharmacy first and all of that lot. correct me if I'm wrong, but pharmacists don't get a fee if it hasn't gone through 111 or whatever, or as a doctor has referred in. If I just walk in and say to pharmacists, can I have some advice about X, Y, and Z? They don't get paid for that. And I'm not sure that I'd appreciated that, because it is extra work for the pharmacy. Let's be honest about it. So I just wondered if anybody can explain a little bit better to me, please.
I'm not sure I can rationalise why, but the issue of community pharmacies been raised on a number of occasions today, and I understand in previous meetings as well. And I think the business sustainability of community pharmacies is now predicated on service delivery, which is predicated very much on the pharmacy first service. So it's an area I've got involved with very much over the past 3 months, because it's an area I see there's huge opportunity in supporting the general practice sustainability agenda that we know is a particular issue in Plymouth, and very much around addressing some of the access issues that have been again, voiced in this meeting and come out in the Health Watch report. Very much predicated on allowing or enabling and empowering our community pharmacists to manage some very high volume clinical pathways, which include tonsillitis, earache, amongst 5 others. However, it does, so the business sustainability of the community pharmacy is predicated on service delivery, and it would appear, speaking to my community pharmacy colleagues, that's predicated on getting referrals from general practice that involves multiple administrative steps. So you mentioned we're about to enter conference season. I think one of the things I would say, if you have the voice of ministers, is to say we have a particular issue with access within the Plymouth system. We are doing a lot of work around our pharmacy first offer, which from a really practical operational point of view, I don't see many areas where there's huge short-term practical operational possibilities. That is very much one area I can see that. And a barrier currently is a non-value adding administrative process in place. So that would be something I would, if you have the voice of ministers, I think that's a practical step that could be actioned fairly quickly. And speaking to my colleagues in community pharmacies and Community Pharmacy Devon, that remains a barrier. I'm doing a webinar with Devon's GPs in about 3 weeks to really try and push the added value and the opportunity here. But I think if you could remove that administrative step, I think that would be hugely helpful, certainly.
So I must admit, it was quite a surprise to me to see that it was clunky, and that was necessary, because I think there's a lot of us that are quite happy to go to our pharmacist, but the thought that they've got to spare time on that when they could be doing something else, it's not fair that we expect a service to be on the cheap. Yeah.
And the unintended consequence, if the pharmacies don't get those referrals and they don't get the income, when we've heard 10% of pharmacies across Devon have closed over the past 12 months, there is a very real risk to the ongoing sustainability of our pharmacies. And we've heard from the public, I know as a practicing local GP with a number of pharmacies that have closed near our practices, the knock-on operational impact and the impact that has for our public and our patients is huge. So actually we really need to be supporting our community pharmacies, and I see this as being something that isn't, from a patient public perspective, particularly value adding really, and actually risks the financial sustainability of some of our pharmacies actually. Thank you.
Yeah, quite agree. Anybody else wish to make a comment? Kathy?
You're promoting digital communication over the winter months, but if you go into the GP surgery, you'll see a notice board and you'll see all sorts of other things that you can access, whereas you lose that communication if you're having a digital communication with your GP surgery. Can you tell me how you can counteract that, please?
Thank you. Yes, that's a really good point in terms of there's a risk there, isn't there, in some of those benefits, and I think that's the key bit really in terms of our making sure that we've got the right communication strategy ahead of winter. So working with partners that we don't rely solely where we are making better use of that digital service. Some of those other benefits and opportunities are also being shared, and I think particularly on a locality basis where we've got some really strong local community-based offers and resources available, making sure that our communication strategy that we develop locally that's informed part of that is also sharing that. We've also got some really good examples of things that have been done. So the local GP who've been doing a social media campaign as well, and they've been highlighting some really positive things that people can do, and signposting to people that they've got awareness of other services that are available outside of kind of that traditional way of communicating with people, and that's something that's being looked to be continued into this winter too.
Anyone else? No? Michelle?
I was sort of going backwards. So it was really around the vaccination programs, and something that came up from the national team was really about people with a learning disability and vaccinations, because they don't actually go into those special groups. But we were asked just to remember and consider that that patient group are also pregnant. They're also have cardiovascular disease, respiratory disease, and making sure that we ensured that they had access to information that is there for people with a learning disability to encourage the vaccination programme. And that was one particular group that, although it's not protected as a group, that was picked out from the national team.
Thank you. And I think
this week.
Thank you, Michelle. And I think that's something that David and Gary will take on board, and Emma in the corner. Thank you. Okay, folks, thanks very much indeed for that. So the next thing is the tracking of decisions. Elliot.
Thank you, Chair. Just a few updates for you today. I've received responses since the publication of this agenda. So if we look at the first tracking decision, NHS clarified that dentistry recalls, routine checkups have resumed. However, some NHS providers may need to push back recalls of patients that are deemed dentally fit to concentrate on those more urgent. The ambition is to return to pre-pandemic levels. And then if we go to the next one, a suicide prevention training session for counsellors has been organised. That is for the 15th of September, and counsellors should all have links to that or invites to that now.
Sunday, 15th of September.
I'll clarify that date, Chair. And the last one, Tony can confirm that it's the Health Watch Carers Survey still being compiled? Published. So I can mark that one as complete, Chair. Thank you.
Excellent. Thank you very much on that. So the work programme, this is your opportunity to influence. I mean, there's been some bits that have come out from today that we'll be adding in. So Gary, you wanted to come in?
I just thought, we've been here today. I think the first item talked about the Darcy report, and I guess I was just thinking, we've got on the items to be scheduled NHS longer term plan. I just wonder whether we should be keeping an eye on that, and maybe changing that into something around once we've got a bit more clarity of that later in the programme. That was my.
I think it's very important we don't lose sight of it, isn't it? So I think that needs to go in for a January update as to what's happened. Don't you, Ruth?
Sorry, Chair, may I just update on that previous item? So we've just checked and it's the 15th of October, the suicide prevention training. Apologies.
I hadn't heard anything about this Sunday, so I must admit. And I think there's some of us, or some people, going to the ladies' footy match, so there wouldn't have been much update. So we can add that in with pleasure. Ruth, your the DPH report will be ready for January?
Yes, Chair, the DPH annual report and Thrive Plymouth, the relaunch of Thrive Plymouth will be coming to Cabinet in, now I can't remember if it's October, no, it's November, the final versions of that. So yes, I'd love to be able to present that here at the following Health and Wellbeing Board. Thank you.
And certainly remind me about the community empowerment programme, Elliot.
I believe that's just an update that was to be confirmed, so I think we'll pick that up in our agenda set meeting, Chair.
And certainly it'll be interesting to see how we're getting on with the pharmaceutical needs assessment, and that's coming back to us in March. And anything else that we've pulled out from today that we need to be adding in somewhere?
I would extend the invite, as we did in the last meeting, Chair, to all board members. If you have items that are relevant for cross-organisation examination, whether that's children's, whether that's from the university, from anywhere, please suggest them and we'll get that, discuss them here and get them added. Thank you.
Well, thank you everybody for your input today. It's been a really interesting and thought-provoking meeting. So I thank you all, and I will close the meeting.
Thank you.
Thank you.